Guys, Dr. Rayfish from Vet Triage. We are continuing through this issue of Veterinary Surgery, May 2022. We are looking at kitty cats today. The evaluation of the superior and inferior labial musculomucosal flaps in cats, an angiographic study, and case series. When they say case series here, they mean two cases, just to be clear. So I would not say it's a case series. I mean, I don't know. I think 3 would be the minimum, but whatever. At least they're trying. The study comes out of a hospital in Michigan, 2 hospitals in Michigan. Objective is to evaluate the angiosomes of the superior and inferior labial arteries, and labial here is the oral area, the lips, not the private area, in the cat, and describe the use of a musculomucosal axial pattern flap incorporating each artery for reconstruction of the palatal defects in cats. This is again important for surgery residents studying for boards because this is going to add yet another flap you need to know for boards as an option for treatment of this disease. They had cadavers, and so 5 cadavers and 2 clinical cases. Methods: the common carotid arteries of 5 cadavers were injected with barium sulfate, and they collected radiographs. Results found the superior and inferior labia were predominantly perfused by the superior and inferior labial arteries, respectively, and the angiosome of each artery encompassed the majority of its respective labium. Comparative positive contrast angiograms revealed that the vascular supply was located within the musculomucosal layer. Reconstruction of the recurrent palatal defects utilizing musculomucosal flaps based on those angiosomes in 2 clinical cases was successful with complete survival of the flaps. Conclusion: upper and lower lips have a robust vascular supply within the musculomucosal layer, supporting a musculomucosal axial pattern flap. Introduction: palatal defects, including congenital and acquired, typically have little surrounding tissue available for reconstruction, poor or damaged vascularity, relatively immobile tissues, localized infection of the tissues due to chronic communication of the oral and nasal cavities, and constant mechanical stress on the repair from respiration, mastication, and deglutition. Numerous techniques of repair include direct appositional closure, single layer vestibular flaps, mucoperiosteal rotation or transposition flaps, double layer flaps, overlapping flap technique, bilateral vestibular mucosal overlapping flaps, medially repositioned double flap, which is also the von Langenbeck technique, split palatal U-flap, palatal island flaps, myoperitoneal microvascular free flaps, auricular cartilage grafts, prosthetic obturators, and tongue flaps. So you're going to want to know all those for your boards. Axial pattern flaps incorporate branches of the facial artery, have been used in humans, dogs, and cats for reconstruction. The superior labial artery musculomucosal flap has been previously described in the successful repair of a large palatal defect for cleft palate in a dog. These flaps are similar to facial artery musculomucosal flaps utilized in humans. All right, clinical case number 1 had a chronic oronasal fistula, radiation therapy for treatment of a peripheral giant cell granuloma along the right maxilla, a caudal maxillectomy for a well-differentiated osteosarcoma, and clinical signs of hyporexia, sneezing, right nasal discharge, dysphagia. CT scan with iohexol was performed in that cat. Transillumination of the left maxillary vestibular mucosa revealed the presence of a superior labial artery. So I want to show you here this picture. It's actually this picture here, and it's an angiogram of the skin on an underlying musculomucosal layer of the face after contrast injection of the common carotid artery. This is obviously a cadaver because the head is severed. And then that's in picture A. And picture B, angiogram of the musculomucosa surrounding the oral commissure after excision of the skin. So then the labels here, little letters: A is superior labial artery, B is angularis oris artery, C is inferior labial artery, D facial artery, E is infraorbital artery. So in case you need a close-up, I guess. Not much of a close-up, but there you go. And the surgical pictures here. This is a pre-op or in preparation for surgery, then intra-op, and then post-op. In the post-op picture, Reconstruction of the palatal defect using a musculomucosal axial pattern flap incorporating the superior labial artery is seen. And then the cat had an esophagostomy tube placed post-op. All right. Clinical case number 2 was chronic oral nasal fistula from a bite wound from a dog. It had a single layer vestibular flap which failed, then an auricular cartilage graft which failed. Transillumination of the left mandibular vestibular mucosa revealed the presence of inferior labial vessels, probably the vein. The location and course were consistent with the cadavers. And so you can see here, this is pre-op, and then intra-op, and then over here you've got the post-op, which I'll read off to you now. For post-op, reconstruction of the palatal defect using a musculomucosal axial pattern flap incorporating the inferior labial artery, and then 2 weeks post-operatively, complete survival of the flap and healing. Note the denuded areas of the donor flap and surrounding recipient bed with presence of healthy granulation tissue, probably due to contact with the abrasive dorsal surface of the feline tongue. Results. For the cadaver study, all cadavers, the angiograms of the superior and inferior labial arteries were consistent between left and right sides and consistent between cadavers. The facial artery branched off the external carotid artery along the lateral surface of the styloglossus muscle near the angle of the mandible. Near the commissure of the lip, the facial artery gave off rostroventrally oriented artery consistent with the inferior labial artery. The facial artery then continued dorsally for a short distance before giving off a rostrally directed branch at the level of the commissure of the lip, which is the angularis oris artery. Finally, it terminates rostrodorsally directed branch consistent with the superior labial artery. Thus, labia are perfused by 3 distinct major arteries: the superior labial artery, the angularis oris, and the inferior labial. The angiosome of the superior labial artery encompassed approximately this caudal 60% of the upper lip. There were extensive branches and anastomoses along the length of the upper lip. Noted. There were extensive branches and anastomoses along the length of the upper lip, mostly noted between the superior labial artery and tributaries from the lateral nasal artery, a terminal branch of the infraorbital artery. The angiosome of the inferior labial artery encompassed approximately the caudal 75% of the lower lip. Similarly, there were extensive branches and anastomoses along the length of the lower lip, most notably to perforating caudal and middle mental arteries. Overall, a robust arterial blood supply perfused both the upper and lower lips, both the intact skin from the lips and the excised musculomucosal tissue. From the lips show the same angiographic pattern, indicating the arterial vasculature was located primarily within the musculomucosal layer. In all the cadavers, superior and inferior labial veins were found to extend along the majority of the length of the upper and lower lips. On gross dissection, the veins were not visible on the angiograms. All right. Discussion. Oh, and here we go, some pictures. So the first picture here, it would be 6 weeks post-operatively, then 8 weeks post-operatively, and then case 2 at 2 weeks post-op. So these are all the pictures here showing the healing. Because such flaps remain attached to the donor site at their base, survival is less reliant on the recipient's bed's ability to neovascularize the flap. This attribute is especially beneficial in cases of palatal defects as compromised of the vascular supply, infection, friable tissue, necrosis of the involved bone, and scarring are present. These challenges are compounded with the subsequent attempts to repair and after radiation therapy. They conclude this indicates that the vascular supply is located primarily within the musculomucosal layer of the entire length of the flap and not within the skin. It follows that mobilizing the underlying submucosa and musculature deep to the mucosal layer is essential for survival of the flaps. Similar conclusions have been reached in studies of labial artery position in humans. In a human cadaver study, the superior and inferior labial arteries were found to reside in the submucosa between the oral mucosa and the orbicularis oris muscle in 78.1% of cases, and intramuscular, meaning between superficial and deep layers of the orbicularis oris muscle, in 17.5% of cases, and in the subcutaneous tissue between skin and orbicularis oris muscle in 2.1%. In the inferior lip, the muscular portion probably includes the orbicularis oris and buccinator muscles. In the superior lip, it is possible that only the orbicularis oris muscle is included, as a comparative anatomic study of the buccinator muscle was unable to identify a maxillary portion of this muscle in the cat. The flaps investigated in this study have several advantages: robust blood supply, large surface area, use of healthy donor tissue distant from potentially compromised tissue surrounding the palatal defect, ability to harvest donor tissue from ipsilateral or contralateral to the defect in the case of the superior labial artery flap, a relatively low arc of rotation, a mucosal epithelium, and minimal cosmetic alteration. Ultimately, the width of the combined alveolar and vestibular mucosa is a limiting factor in the width of the flap that can be harvested. Distal ischemic necrosis is a concern with all axial pattern flaps and is a primary concern for the labial musculomucosal axial pattern flap. In this study, it has been shown that venous drainage of flaps is more important than a larger arterial supply for flap survival. Inclusion of the superior labial vein for the superior labial flap and the inferior labial vein for the inferior labial flap is likely to be critical for flap survival. The general rule of axial pattern flaps should not be rotated more than 180 degrees to avoid venous congestion and flap necrosis. In some cases, dental extractions are necessary to reduce or prevent postoperative trauma from occluding teeth and compression of the flap when the mouth is closed. While feeding tubes are not typically necessary, if warranted, it may be preferable to place an esophagostomy tube prior to surgical reconstruction to prevent undue trauma to the surgical site. Another inherent disadvantage of this technique is the replacement of a sturdy keratinized palatal mucoperiosteum with more fragile non-keratinized lining like alveolar and vestibular mucosa. In addition to full healing of the reconstruction and resolution of clinical signs, other postoperative interests include maintenance of the ability to open the mouth, close the mouth without hindrance, and having cosmesis. Absence of or decreased sensory innervations to the lip due to the necessary severance of nerves coursing through the flaps is likely. Maxillary and or inferior alveolar nerve block can be performed for analgesia. Any iatrogenic trauma to the parotid and zygomatic ducts and or papillae located dorsal to the maxillary fourth premolar and first molar respectively is possible and could cause a sial seal requiring duct ligation or sialadinectomy. That's it. So, it's an interesting study, a good start. It's a very small study, of course. But oral surgeries like this are very frustrating for veterinarians who try to perform them. They are very, very annoying. So it's good to have other options. This is more of a study for those who are taking surgery boards. That's really where this is going to come into play. All right, guys, we'll see you in the next video. Thanks so much.